Hi, everyone. Thank you for joining us this afternoon for our webinar on demystifying the CMS Interoperability Final Rule. If you could go to the next slide. First, we will start with a few logistics and housekeeping items for today's session. So first, today's session is being recorded and all attendees will receive a link and follow-up to watch this presentation on demand. Your phones will be muted upon entry when you enter the webinar, so we will not be able to hear you, but throughout the session, we encourage you to send us any questions that you might have, and we will address them at the end when we go to our Q&A portion of the webinar. So please feel free throughout the presentation as any questions come up to enter them in the GoToWebinar chat panel that you can see here on the right-hand side of your screen. And yes, if you could go to the next slide, I will introduce you to today's presenters. So today we have a panel of experts, and our first presenter you see here is April Todd. She is the Senior Vice President for Core and Explorations here at CAQH. She is responsible for leading the CAQH Core multi-stakeholder collaborative that's driving the creation and adoption of operating rules for healthcare data exchange. She also directs the explorations function for the organization, including research for the CAQH index and innovations and interoperability, including our newest solution, the CAQH Endpoint Directory. Next, we have Lee Barrett, who is the CEO and Executive Director of the Electronic Healthcare Network Accreditation Commission, or ENAC. ENAC is a federally recognized nonprofit and standards development organization that is designed to improve transactional quality, operational efficiency, data security, enable operability, and ensure stakeholder trust in healthcare. And finally, we have John Kelly, who is a principal business advisor at Edifex. John is a nationally recognized health information exchange expert who provides strategic consulting to Edifex customers, specializing in information exchange and applying the principles of supply chain integration to the healthcare delivery lifecycle. And if you'll go to the next slide. Our agenda for today is to first start with understanding the CMS Interoperability and Patient Access Final Rule. So really get into the detail on the rule and what you should know about it. Then we will get into the challenges facing health plans and app vendors as the different requirement dates pass and what it will mean on the industry as a whole. And then for the final portion of our presentation today, we will get into some questions and answers. So here we are really wanting this to be a conversation amongst our panelists, and also we want to incorporate questions that you all have for us and for our experts. So like I mentioned beforehand, any questions that come to mind, please feel free to put them in the chat box and we'll make sure to address as many of those as we can. So without further ado, if you will go to the next slide, I will pass it over to my colleague, April, and she can get us started.
Great. Thank you, Sam. Good afternoon, everyone, and welcome to our webinar, where hopefully you will learn a bit more about the CMS Interoperability Rule and how you can successfully navigate some of the challenges in responding to the rule. So first off, I want to start and give an overview of the main components that are incorporated into the interoperability rule. There are some key components to the rule that are important for the industry to be able to address. And really, this rule applies to plans that have CMS regulated programs. And what this means is plans that work in Medicare Advantage, that work in Medicaid managed care, also are state Medicaid organizations that run Medicaid fee-for-service programs as well. It also includes the exchange plans and also CHIP plans for children as well. And so what's included in this rule for those particular CMS regulated plans are a few key components. First is to implement and maintain openly published HL7 FHIR-based APIs in order to provide patients with access to their health information and to provide provider directory information as well. And this needs to be done in a multitude of different ways. First, and in particular related to the patient access API, health plans need to permit access to data to third-party apps at a member's request. Health plans also need to be able to support electronic exchange of data for care coordination as patients move between plans. So as members want to have their data to move from plans to plans, current and past plans of a member need to be able to support that. And then lastly, there's also some direction within the rule as well that to help members be able to make good decisions around use of their healthcare data, for plans to provide information to their members to help them protect the privacy and security of their health information. Now, under this rule, if we can go to the next slide, there are a few important dates to know. I think many of us are familiar with the May 2020 date where CMS issued the final patient access and interoperability rule, but there's two important dates as well that relate to the requirements that I just went over. The first is a date that already has occurred this year in July 1st of 2021. And this is where CMS is enforcing the requirement for plans to provide access to patients through a third-party app to be able to access their patient information. And this is really at a patient's direction. Another date of another importance that is coming up here in January 1st of 2022, is for payers to be able to exchange data with other payers to support a patient in their care coordination and being able to transmit data from a prior plan to a current plan. What is different between these two dates is that the first one in July of this year required the use of FHIR APIs to be able to exchange that information. The January 2022 date to be able to exchange information does not require use of a FHIR API. It allows the data to be exchanged in multiple ways and in particular in the mechanism with which it was received. So if we can go to the next slide. Want to highlight a couple of different components of a general workflow that both plans and apps will need to think through for being able to exchange data between payers and apps to support patient access. So one of the first ones for apps to think through is requesting the connection. And one of the first things to do is to just find a payer to be able to connect with. And to be able to submit information to that payer, to be able to validate their identity, share information on security and privacy and data use, and to be able to request an actual connection. And so the payer then needs to be able to review that connection request and evaluate information submitted by the organization on identity and security information. And what's really important here is that as a payer reviews information from an app, a payer cannot decline a request for connection unless there is a risk that the payer sees to its systems, whether it is security or technical related risk for the plan. So the plan then needs to evaluate that to approve or deny the connection. But there's other information that the payer will want to have from the app related to privacy and data use. To be able to share that information with their members so that the members can make informed decisions around how to share their data. And lastly, the payer will need to be able to share with the app how to access their credentials so that they can be able to start sharing data for that member. So an app will then need to be able to request credentials. And in order to do that, be able to test with the plan to ensure the ability for a effective and secure connection. So you're getting the data in a structured way that is secure and making sense. And then the payer is going to need to grant credentials and notify the app of those credentials so that they can make that ongoing use of the data. And the app will then need to get those credentials and update that information in their identity access system. So That's a general workflow. There may be some different steps along the way that apps and payers may use to help satisfy these requirements. But these are really kind of the core components to facilitate access to member data at a member's request. So we go to the next slide. I want to review the general payer-to-payer workflow. And this is really the workflow for a current payer to work with a prior payer of a member to share that data on the member, so to help facilitate care coordination for that member. Now, what's interesting about this workflow is there are different ways in which the payer can share that information. And what you'll see in this slide is the ability to potentially do that via APIs in a similar way to how the patient access API could work, but also not using APIs as well. But generally along this workflow, there are still some key components that payers need to think through in this particular workflow. So in particular, when looking for past member data, current payers are going to need a way to gather member request and consent. They're also going to need a mechanism to find where members previously had coverage. And on this particular item, some plans may rely on members to know which prior plans that they had. But in many instances, members may not remember or have the detailed enough information to be able to facilitate that connection with a prior plan. So requesting payers also need a process to match a member with another payer to make sure that they are talking about the same person. And they also need a way to find where to go to get the member data. Now, for a prior payer, when a prior payer is looking to send a member data, they need a way to ensure that data requests are from valid current payers of their past members. They also need a way to communicate their process for how these payers can access past member data. Now, if there is a process that can be used for an API, these payers need to be able to exchange data via API, and they need to test to ensure that that can be an effective and secure connection, need a way to issue credentials, notify the requesting payer that credentials have been granted, and for that current payer to be able to access those credentials. And then lastly, regardless of how the information is shared, the prior payer needs to ensure that the data is shared securely with the requesting payer. And so again, these workflow steps may be slightly different from payer to payer, but these are the general components that would allow a requesting payer to access a member's prior data with that member's request or consent. And so if we go to the next slide, as we think through the requirements and the general workflows for apps and payers to be able to satisfy this requirement, there are a few challenges that exist for plans and app vendors within the industry. One is just an unwieldy volume of potential connections. When you think about all of the health plans that are currently regulated by CMS, either serving Medicare Advantage or Medicaid or the exchange or CHIP enrollees, there are a number of plans within that market. And as you also consider that they need to engage not only with each other, but also with app vendors to share information, the potential connections are in the hundreds of thousands to be able to share this information. So managing those connections can get quite complex. So if we go to the next slide, you can see that these connections, and given the steps that are involved in them, they can be quite tedious and time consuming. First, you need to determine whether a connection is needed with someone, and you need to be able to find the endpoints to be able to connect to and make sure that those endpoints are active, that they're maintained, they're reliable, can be trusted. You also need a way to make a request for a connection, for someone to know that you want to connect with them. And also a bit dicey is being able to match a member, gather their consent, make sure you're talking about the same person. And then there are operational, legal, technical hurdles to make sure that there's trust between trading partners and that you can exchange things in an effective and secure way. And then lastly, just credentials exchanged. And so when you think about these connections and the different steps that are involved in that and those challenges, and the fact that you need to repeat this process potentially hundreds of thousands of times, that can be quite a bit of a challenge. And so those are some of the challenges that we'll look to talk with you all today about and answer questions that you have. So if we can go to the next slide. So one of the key things within this new ecosystem of sharing information is to promote trust. And that involves, making sure that we are dealing with good actors, that we know the identity of the organizations, that they are who they say they are, that we are protecting security, that we are protecting the privacy of member data, having information about data use. How is the information going to be used, and are members okay with that? Also making sure that there's testing, appropriate testing that is occurring to make sure that we're exchanging things in an effective and secure way. And then maintenance, making sure that any information that's available doesn't become stale so that it is trusted. And so these are a lot of the challenges that people are thinking through and engaging in now that the 1st July compliance date has come upon us. So in particular, in terms of the challenges, there's the realm of authenticating, and this is really just checking the business credentials of payers and apps. Are they who they say they are? Secondly, gathering information to evaluate system and technical and security risks. Making sure you're protecting your system from those that would want to engage with you. And also obtaining member consent and making sure that you are matching to the right member and the same person between plans. There's also the challenge of educating. And what's included in here includes collecting and communicating information on privacy and security and how data will be used. All of that information to help members make informed decisions. Really, this interoperability rule has put the decisions for data use into the hands of members. They are in the driver's seat, but we need to help them understand and make sure that they have the information to make good decisions. And so that ensures making sure that we are ensuring that payers and apps, have that information and that they can locate and connect with endpoints, and that they have that information that they need. Another challenge is testing, and this is, validating that endpoints are active, that they're FHIR compliant, that they're structured in a way that for effective use. Also testing between payers and apps to make sure that there's secure connections. And then lastly, a challenge around promoting trust is maintenance. And this one is quite important because we know that there are going to be endpoints available all over for people to be able to access. But do we know that they are active, that they're maintained, that the information can be trusted? And so we really want to make sure that we are ensuring that endpoints and information are up to date, and that any changes are communicated to payers and apps and members, and so that we don't let that information go stale is another challenge. So with that as background, if we can go to the next slide. We wanted to use much of our time today to answer some questions from the audience, talk about what we have heard most recently from the industry on the experience and the questions that we have had coming in. And so we will start off with a few common questions that we get. And so I'd like to invite my presenters to turn on their cameras with me. And again, would remind you all that if you have a question, to please submit it in the question box so that we can see those. Thank you, Sam, for turning that on. So you can see here a graphic. If you have a question, please submit it in the question box, and we will be happy to answer those questions. If we are unable to answer your question today, we will definitely take them and put out answers to questions on our website for those that we are not able to address today. So with that, Sam, I will turn it over to you to get us started here.
Yes, thank you, and great job, April, on setting the stage for all of us. We have already been seeing a couple questions come through. So the first one is kind of a softball, and between Lee, John, April, I'll let you guys all, interject where it makes sense based on your areas of expertise. So the first one we have is, what is the most common question that you get on the CMS Interoperability Rule?
So I can maybe start with the most common question. The most common question I think that we get is actually is from payers, and the question is, you know, what are things that I can do to evaluate a plan or evaluate an app? Do I need to allow an app to connect with me? And so, you know, based on some of those questions, I think there's some maybe misunderstanding of the rule in some among some plans around the role of the member, and that the member is really, you know, responsible for evaluating the data, deciding how their data can be used, whether they want to work with a particular app. And so, but members need information. And so what payers can do is they can collect, and what they're encouraged to do is collect information from the apps to provide to their members so that they can make good decisions. But what a payer can do and should be doing is getting information on the identity of the organization, some security and technical information to make sure that their system, that there's not a threat to their system. So those are the main questions we get is, you know, what really should we be getting from an app when we're thinking about connecting?
And we're hearing, you know, it's a great question. We're hearing from a number of the industry, really, when you start to look at it as far as the rule, how are we going to deal with, you know, privacy and security, not, you know, across the spectrum. And April did a good job, I think, of talking about the whole issue of promoting trust, stakeholder trust, and actors. But there's a lot that's going on here in relation to being able to demonstrate, especially when you start to look at third-party app developers and being able to have them demonstrate their level of ability to meet privacy and security. And then you've got, you know, all of the other entities as well that are there. And then the other big question that we hear is about, you know, how is the industry going to be able to scale big enough to be able to handle and automate all of these various, not only third-party app developers, but all these APIs. And so the whole issue of authenticating between all of these entities, the whole issue of the standards, and the ability as well to kind of not only authenticate, but also register all of these apps dynamically, are all issues as well that we're hearing as far as major issues in the industry that people are looking to deal with too.
Yeah, and I guess I would totally agree with, I think, the security and the privacy, because that's been part of our DNA for 25, 30 years now under HIPAA, and understanding and being in the context of it mostly being exchange between payers and providers, that it's really what's created a lot of confusion and lack of information is that CMS, what they did was fairly radical and really pivot and make information exchange in healthcare no longer about payers to providers, payers to government, you know, employers and payers and employers and providers. They made it all about the consumer. And I think the biggest questions that I saw changed over time. It was so radical, I think, back in March of 2020, that, you know, the first question that I was hearing constantly from a lot of my customers was, this doesn't really apply to us, does it? I mean, it was just a sense of disbelief they had to do this. How can you tell me I have to give patient information to someone that I don't know, right? And then when they got to that, the next question was, well, it's all information I maintain. So, well, what does the word maintain mean? You know, in some of the forms of Da Vinci and Weedy, you know, there was a significant amount of time asking CMS to define what the word maintain means. You know, what they came back with was, do you have access to it? Do you have control over it? And do you have the technical ability to give it away? And if you do, then give it away. And then the next thing was this whole idea of USCDI. We're used to dealing in data elements that are specifically identified in an X12 transaction, you know, referring provider, ordering provider, you know, tax ID number, payer ID number. Now you have this thing called data classes in USCDI, and it's kind of like this conceptual model of information that was designed for EMRs, and now payers have to kind of take all the data they have on patients and put it into these buckets, and then figure out how to turn it into FHIR. And I think so those questions evolved steadily over time and we're just wrapping up some of the patient API questions, and now there's this whole new cycle of lack of information related to payer to payer. So, I mean, I think there are just so many questions associated with the radical nature of what CMS did that I feel like the industry is still grappling just with that, you know, without even getting down to brass tacks.
Yeah, great. Thank you all. I have one housekeeping request for our panelists. I think some people are hearing some echoes when we're talking. So as we're each talking, if we could try to mute and unmute when we're speaking, I think that might help a little bit. So we're getting a ton of good questions. So appreciate everyone on the line writing those in. The next one that I have here are, what are the primary questions or concerns you're hearing from payers regarding the upcoming requirements for payer-to-payer data exchange in January?
I'm happy to start on maybe that one as well. I think the main questions that we're getting within the industry is without a requirement for payers to exchange this information in a particular way, so that the FHIR APIs are not required for this particular data exchange, there's some confusion here around having a standard approach to do this, and some concern that it will be done in a multitude of different ways. So we know that there are a number of payers that are looking to use similar FHIR-based APIs to what is being used with the payer-to-payer data exchange. I think there's some momentum there to try to use those mechanisms to help streamline how this information is shared, because there really is a lot of interest here on behalf of the payers to be able to exchange this data. You know, current payers have said that if they can get access to past member data to help with care coordination, that they can really reduce burden for some of their providers. They don't need to be you know, asking the same questions of providers or regarding gaps in care and quality measurement. You know, they will already know that a patient, you know, a few years ago had an amputation, and they don't need to ask that again, for example. So I think there's a lot of interest here in making this a more standardized process, but there are a lot of questions around how this is initially going to work when there isn't a required way to exchange the data up front.
Yeah, I'll jump in, and I think the lack of standards, at least with the patient API, they gave us a lot of references to the ONC rules about FHIR and things like that, Open OAuth, OpenID. In payer-to-payer is really more of a standard of performance. You had to be able to do something. How you did it's kind of up to you. So the idea is that, technically speaking, to comply, an old payer sending to the new payer could say, I'm just going to dump everything into an electronic folder, and I would like to set up an SFTP connection with you. Technically speaking, that would meet the requirements. It's a nightmare in terms of how that would work if you want to scale that for millions of people, tens of millions, hundreds of millions, I guess, in the long run. And so one of the big questions is, can I just rely on FHIR? Can I just leverage all of the investments we made in the patient API and go that route? So there's been lots of conversations that, you know, among the different groups at, you know, WEDI, DaVinci, CAQH, different places about what is a model that can work that would be compliant. And so a lot of back and forth has gone on between those groups and CMS to say, if you use what we put out there in the rule that was published and withdrawn early January around kind of all FHIR all the time, you'll be okay. And then I think the other bundle of questions really were about, as April alluded to, how do I find and connect? How do I know all these other payers that I have to connect and reach out and connect to them? And again, I think people want to hear the answer that it's okay to leverage my FHIR API infrastructure and leverage some of the standards that are coming out of the ONC FAST group and whatever. I think, you know, in other forums, CAQH has talked about, you know, the opportunities to leveraging those standards for finding and connecting. So I think largely it's really about, and I think actually there's one other major one, which is, I think this is near and dear to Lee's heart, is, you know, how do I know it's the right member? How do I know that I'm matching the right records to that member? And how can I feel comfortable that even though the third-party app vendor is not covered by HIPAA as a covered entity, there's only FTC laws that cover them, but the payer's still on the hook to make sure that a breach doesn't happen. So I think those are all of the areas that are wide open for payers, and there are no hard and clear answers. We're going to be dealing with case law and consensus approach toward January 1, for the next 130 days.
I think the other thing, John, that you were talking about, which is important, and then April, you kind of alluded to it as you were going through your presentation as well. It goes back to this whole issue around scale, for the payers and the number of connections that they're going to have to manage. A, B, I think as well, John, you talked about all these third-party app developers. We're hearing from a lot of payers as well. Their concern about any of these third-party app developers that they've contracted with to manage all their apps and for that organization, that they want to put in some type of oversight to assure that those third-party app developers are in fact meeting their privacy and security requirements, that they've got some type of, again, leverage to assure the quality of the APIs that are being developed and being delivered and being used on their behalf. So all of those, I think, are additional issues. And in fact, that's one of the aspects that we looked at is from an ENAC perspective, which is why we created a separate program as well to be able to go through and to demonstrate for whether it's payers or other actors to be able to go through and have these third-party app developers to go through to demonstrate their compliance with privacy and security, how they're dealing with the fire as well, because that's going to be extremely important from a standards standpoint, that we've got standardization and that we can address the payers can address this whole scalability issue as well and demonstrate that level of stakeholder trust. So I think those are all key issues that as we're looking at kind of the payer-to-payer exchange, that are the challenges there.
Lee, if I may maybe ask you a question, follow up to that. I think you kind of alluded to what payers do to their due diligence, and I think we've all seen that the first round of these third-party app developers most of them are trying to create a business relationship with payers, and then the payer sponsors those apps on behalf of their members. I think when you listen to the Anish Chopras of the world talk about the new health app economy, they have a very, very different view. And I don't mean to single out any one app, but one that I find very promising is an app out there called One Record that I was able to go out to the App Store on my iPhone, download the app, and then using the FHIR standards, just connect to payers and get my COVID vaccination data immediately. And so I'm wondering whether you're hearing the payers anticipate not just how do they do due diligence on these people they have a relationship with, but how are they going to handle when we get to where the Anish Chopras of the world say we're going to be in 2 to 5 years, where any patient can download any app they want off the App Store and then basically demand their data be downloaded?
I think it's a very interesting question, John, and I do think today, we all know today when we're going to get our information from PCP or specialists, et cetera, we're going on to multiple portals to get that information. The intent, obviously, of all of this is to try to get to kind of a single and seamless way that we can all get our information rather than going to all of these various portals to do so. So you're looking at, access. You talked about all of the third-party app developers as well. And I think, again, going back to a lot of the health plans, similar to what they do today, John, a lot of these health plans today go through what's called a third-party assurance. And they contractually require any vendors that are acting on their behalf to actually have to meet third-party assurance requirements in an effort to reduce their overall risk of a breach, cyber attack, etc., from their infrastructure. And they will have organizations go through it. These vendors, third-party vendors, go through that. And ENAC, HITRUST, there are several frameworks that meet those requirements in an effort to reduce that risk for a health plan. I think it's a similar process is going to take place for health plans, in which they're going to look to require third-party app developers, whoever it is, whether they're acting on their behalf or some other way, but to have some type of process so that the privacy, the security, they need to at least validate that any of these third-party app developers have the appropriate infrastructure, they're adhering to the standards, they're using the appropriate protocols, as well as best practices that particular entity wants. And I think that's how this is going to play out to meet kind of, as you said, kind of how this will work, and how Anish Chopra and others are talking about how this in fact will evolve. I think there's going to have to be that level of kind of security, privacy to develop that level of stakeholder trust that's going to be needed with these various actors going forward in an effort to scale this. I don't know, hopefully that answered your question, John.
It answers the question. I hope you're right, but I fear that, human behavior pushes the market in a different direction, unfortunately. And the rule doesn't, the rule actually encourages that behavior. So we'll see. I hope we are smart before we're stupid.
I hope so too, John. But I do think that there's a lot of good best practices and a lot of good work that's been going on with the Fire at Scale Task Force, the FAST Initiative, HL7, Da Vinci, Smart on Fire. I mean, there's a lot of great initiatives that have been going on in the industry that we're all able to leverage from right now. And I think we're seeing a lot of these best practices, a lot of these, as well as standards that are continuing to develop. And I think the testing and what we've developed with this trusted accreditation program that we've developed, and our trusted network, app that and testing that we've put in place as well to test not only Fire APIs, but to test the servers and the servers as well, is our Trusted Dynamic Registration, Authentication, and Accreditation Program, or TDRAP. And those types of things, I think, and those types of initiatives are going to help to develop that level of stakeholder trust that we're looking to create, along with the Endpoint Directory and those types of services, I think are absolutely critical for the industry.
Yeah, so I have a question that I think kind of goes along with the conversation that we've been having for the past couple of minutes, which is how many approved third-party apps are in the market, and what would be the incentive for them?
I can start, just tell you kind of what we are seeing. There are a number of apps that are coming into our endpoint directory. There are also a number of apps that are accessing the Blue Button initiative that CMS has. Right now that's probably between 60 to I think 100 different apps that are kind of within that ecosystem of wanting to access that. And so there are apps that are starting to emerge, but I would anticipate that the longer these rules are in place, there will definitely be more that see an opportunity to do that. And I think, and be curious what Lee and John are hearing as well, but there's a lot of different ways that the apps can help, can have a business model with doing a number of these activities, whether it is, helping to support plans with care coordination, whether it is helping, members, manage their medications, manage their chronic diseases. There's a whole host of different ways for business models for apps to, in particular, I think, help members with some of their chronic conditions.
I'll tell you, there are a very large number of healthcare apps that are developed on an annual basis. I think that the number of new apps that are being developed are in the hundreds of thousands on an annual basis. And as April was talking about, we're just seeing a lot of these apps that are out there, and really the bottom line is that they are certainly trying to help and enable patients to have a lot more information, whether or not it's being able to take all of their vital signs and being able to communicate with their PCP or specialist, to a number of others that are managing prescriptions, treatment plans, etc. So there's a lot of great apps that are out there. The problem that we've seen, and we've worked with a number of organizations as well, is in many cases, a lot of these are not being vetted as far as privacy and security and how good they are as far as people being able to hack into any of them to gain access to data. So that's a big part of it. So I do think that as we're looking at third-party app developers today, and we're looking at where we're looking to go with this, I think the whole aspect, going back to April, what you were talking about throughout the entire presentation that you gave, goes back to stakeholder trust, and it goes back to assuring whether or not it's going to be between payers or at the patient level, or between other actors. The key is going to be how we look to secure this data, being able to demonstrate the level of security as all of this data. We're going to be seeing a tremendous amount of data exchanged, not only through the APIs, but as we start to see the entire process of interoperability move forward with qualified health information networks, as the trusted exchange framework with common agreement starts to take shape in probably 2022, and we start to see a common agreement on how this is going to take place between all these entities, and obviously all of the payers and the various stakeholders that will be doing this. So the need to have a way to, one, increase the scale on how we look to register all of these apps. These is going to be critical, as well as authenticating patients, and as well as the payers themselves are going to be important. And so as we start to look at some of this, the Unified Data Access Profile, the UDAP standard on how to assure and leverage the level of trust and security as far as registering, automatically registering dynamically a lot of these, and assuring compliance with the standards, FHIR, etc., is going to be extremely important. So those are some of what we're seeing.
Yeah, and I think you guys have nailed it in terms of the patient APIs and what's happened with the rule. It is a limited number of apps that are actually out there in the business working, and which gives us a little bit of time to control it. But when you think about a lot of the numbers that came out during COVID, what the upsurge in people who used mobile apps on their phone that were healthcare apps, it was crazy. There, literally like 100 and something thousand was at least one number I heard of apps that were born and got adopted over the last 18 months. And when you think that the business model for all those apps is usually, most of them you don't pay for as a consumer, they make their money on what they find out about you. That's how that app economy works. And so the idea that there's now a tsunami of data now coming online, that if they can convince a member to just log in with their right credentials, they can get at that information. we're going to have a lot of those 100,000 apps that are bad actors. Most of them are going to be good actors, I would say, the majority. And what they're going to do is take that information, they're going to create value. On a recent webinar, I heard, Alex Mungy from CMS talk about shoppability. Just provider directories alone, the ability for app vendors to get access to all this information across all the payers in the United States, and basically be able to get a consumer to give them some information, and based on that information, be able to say, I can pick the right plan for you, I can pick the right network for you, I can pick the right doctor, and it'll work. It's not a lot different than dating services or auto insurance services that we now see, where people use app technology and create value for consumers. So that's going to happen, but it's going to happen quickly in healthcare. And I think that's the one thing that, I think both April and Lee are both working on so many different projects to see if we can get out in front of that before, the tsunami causes some of these train wrecks that the privacy advocates are very highly concerned about.
John, you were talking about, all the apps that happened over, COVID, over this past year and a half. Add to that telehealth and how telehealth has taken off as well. When you think about, everybody was at least familiar with telehealth before, but then during the pandemic, everyone was using telehealth. And so that again, a tsunami of additional apps was developed just to dealing with telehealth. But all of these, if you start to look at all these apps, it still goes back to when you were talking about the data. You're right. That's where they're making their money is on the data, the information that they have. The key, therefore, is because there is so much data and there is so much clinical data and other information on all of us, the key on securing, being able to assure the level of security and privacy of how that data is handled, and the consent aspects by patients are absolutely critical here. So all of this kind of all factors in to how we're going to be managing this tsunami of data, the number of apps, the third-party app developers as well, and all the actors. You've got to have, whether it's a payer, the providers, we've got to have all of the infrastructure in place to be able to validate, verify, and authenticate all these various entities that are going to be accessing this data.
Yeah, I'm wondering, April, I think what, I'm putting out there this idea that there's some real questions. And I think Lee's emphasizing that those who do have the fortress around the data are doing everything we can to put the mechanisms in place. A lot of internet control is based on routing traffic and connecting and making sure that people are certified at the endpoints. Is this a primary goal for what you're doing in terms? You're doing some nuts and bolts work, but are you also applying this idea, whether it's patient matching or whatever, to help lend some structure to this Wild West traffic?
Yeah, so there's a couple of things that we're doing. One is with the Endpoint Directory, and particularly around the patient access API, and supporting kind of the interaction between apps and plans is, collecting some of that information around, making sure that we have information on identity, that we can validate that we are collecting information on privacy and security and how data is going to be used, and doing that in a structured way. As well, collecting information on whether whether apps have gone through the process that Lee was talking about with TD-RAP, to make sure that they've gone through that security process. We're asking those questions so that the plans have the information, but more importantly, they're able to share that in a standardized way with their members. Now, what we're not doing is we're not using that information to say, hey, as an app, you can only access the Endpoint Directory if you've done all these 5 things. Because we want all the actors to be in the Endpoint Directory. It's intended to be a utility for the industry that, whether they're, good, bad, or ugly apps, that they're all in the Endpoint Directory, and we have information on how they're going to use the data and what they've gone through from a security perspective, so that members have that information and they can make good decisions. So that's one of the things that we are doing. In terms of member matching, we have also recently started to work on some support for health plans for the payer-to-payer data exchange to help with the identification of prior plans and matching the members between those plans. Because as I mentioned before, you know, there are some members who know their information back 5 years of where they were enrolled, but there are a lot of members that don't, and they won't have their past member card, and they will know maybe I was in a Blues plan, but they don't know which one, or I was in Medicaid, but I don't know which Medicaid plan I was in. So they can't really provide direction as to where to go. But CAQH has some assets that can, data assets that can help find those past plans, and some algorithms that we've used for a number of years to help match patients to support coordination benefits. So we are looking to use that to help support this process as well, and bring some integrity to the system.
Great. I know it's hard to believe. I feel like the time has flown by, but we only have about 9 minutes left. So before I kind of pose the last question, I wanted to just tell everyone on the line, we've gotten a ton of good questions, and we definitely will not have time to answer them all, but we are planning to, in follow up with the slides and the recording, we will put together an FAQ and answer some of these questions that we got, because there's some really great stuff here. So the last question that I'll ask that I think maybe each of you could take a minute to answer is, it's shifting gears a little bit, but what are the expectations for the top 3 use cases in the next 2 to 3 years for this initiative that would make this a success for CMS?
Well, I'll jump in quickly. Certainly, CMS has established a goal for payer-to-payer to establish a longitudinal patient record for patients. That since patients move around a lot between doctor to doctor, presumably one of the places that there's some centralization is the people paying for the claims are storing that. And if every payer then creates that chain between payer to payer to payer, accumulating also all the value-based care information, they'll have a lot there. So I think, you know, I'll say one of the top use cases that I see where CMS, the member and the payers are all aligned is this notion that understanding the risk of a patient's risk profile based on history, and then also understanding what's the best way to coordinate care across multiple entities. To me, those are major goals expressed by CMS in the law, and I think that all the stakeholders are aligned around that.
I think the other thing I would just add to that, Sam, is the fact that I think as we start to look at these use cases, and we're seeing a number of use cases which will continue to be developed, but the 3 major ones, if we can look to create out of these use cases best practices that can be used across the industry. 2, that as new use cases are developed, that we identify, even out of the ones that we have, what are the risks? I think going back to what John was saying, are there any additional risks? Are there any additional areas that we should be concerned about, and address those? And then 3rd is the whole aspect about leveraging the standards, whether it's HL7, whether it's the Fire at Scale Task Force, what they're doing, what Da Vinci continues to do, as well as the Argonaut project as well, and other initiatives, for example, Smart on Fire as well, leveraging what they're coming out with as far as best practices and other items, and then leveraging, I think the other thing, going back to, I guess, my soapbox on privacy and security, is leveraging some of the profiles that are out there, like the Unified Data Access Profiles, UDAP, for assuring one, that we can get to the scale that we need, and 2, that we can assure that the appropriate standards and best practices are being used, and leveraging this PDRAP program that we put in place for demonstrating, and then the directory services. I think those are the types of things that we can look to take away and look to enhance not only those 3 use cases, but build on them with additional use cases that'll be developed.
And then, I mean, I would say that, we have 2 to 3 use cases that are the first ones out of the gate from CMS. We have the patient access API, we have the payer-to-payer data exchange, we have the provider directory API that's out there. But I think, underneath all of those use cases, what you read in almost every publication that comes out from CMS is that they're looking to support patients and members and in their ability to support care coordination for them to be able to use the data how they want it used. And so, I think, if I'm pontificating into the future here, I know CMS has started with, Medicare Advantage and Medicaid and, the exchanges, but typically when CMS does something like that, they're trying to encourage the industry to, move things forward on a broader scale for every patient and every member. And so I think that would be kind of, if I'm thinking future, glass ball here, that they would be looking to, provide this for everyone. But to that point, I would maybe just as we're closing up here on the call, we have had some CMS colleagues that have joined us on the call, and they have they have put up here that and asked us if we could direct people to, if they do have additional questions, that CMS does have an FAQ on their website. They're looking to get questions. They're hoping to answer some of those questions. And so there is a site at cms.gov. If there are some very specific, very technical questions that we may not be able to answer, please use that website and submit questions there. And to Sam's point of earlier, we have gotten in a lot of questions and have been trying to go through them and consolidate ones that are similar to answer them today. But promise that we will get to the rest of them that we haven't been able to get to today and make them available to all on our website. And we'll also provide the link for the CMS FAQs as well, so that folks can get their questions answered.
I just wanted to put a plug. I think CMS has done a great job in providing a really good website with FAQs and the information that they've been doing. And I think, CAQH, I believe, HL7's done a great job. The Pirate Scale Task Force, sponsored by ONC as well. There's a lot of great resources out there. ENAC, I mean, all of these entities, you should avail yourselves of all these really great resources and really good information that's out there for you to really get this information, see what the FAQs are, and really learn from them as you're developing your entire strategy going forward here.
All right. Well, thank you, April, Lee, and John, for taking the time to sit down with us and answer some of these questions. And thanks for everyone who joined today and put in some really thoughtful questions. So hope everyone has a great rest of your day, and you'll be hearing from us in follow-up to the webinar.
Thanks, Samantha. Lee?
Thank you.
Thank you.
Bye-bye.